Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Chernayanu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. This episode is all about the timing for estrogen therapy. When do we need to start hormone therapy for menopause? Obviously, estrogen is the king for that type of therapy. And what is best? This is a very important and crucial matter to discuss. And as I promised in my last episode, I am going to continue this discussion on the hormone replacement therapy by focusing on the timing. Why? Because, many women choose to ignore the benefits of the right timing and decide to use estrogen therapy as they age, and it's obvious that changes have happened that they're not happy with and they would like to reverse them. And by then, it's already too late. I have already shared with you one of my mottos and beliefs. It is never too late for estrogen. And that is what I applied to my mother's care when I started her on estrogen therapy at the age of 72, 30 years after her very early premature surgical menopause. Now, in order to understand why timing of therapy is critical, I would like to talk about the findings of the WHI study, and I have filled your head with this stuff for the past 3 episodes, but I want to talk about what it meant for the cardiovascular system for women who were older, menopausal, enrolled in the study, and were given this type of estrogen, the synthetic hormone estrogen. If you remember from the previous episodes, if not, it's always a very interesting listen. So please go back and check that out. I shared with you that the WHI study rocked the medical world as well as the entire female population who happened to be on any estrogen hormone therapy after menopause at that time. It was designed and conceptualized and controlled by the National Institute of Health, the NIH, specifically the National Heart, Lung, and Blood Institute, which was how NIH funded the WHI, the Women's Health Initiative study. It was launched in 1991 under NIH's first woman director, named Bernadine Healy. Now, this study was not designed, as I shared with you before, by any hormone specialist, even though it involved hormones. No hormone expert was consulted on the design of the study. They literally did not feel that they needed to do so, and I'll explain why. At that point in history, there was not a significant diversity of available hormone therapy. Oral estrogen in the form of synthetic pregnant horse urine estrogens alone or combined with progestin to protect the uterus for women who needed the progestin. This type of estrogen, the oral estrogen, Premarin, reigned supreme. It was the top number 1 prescribed medication by the late 1990s in the United States. I did share with you in the previous 3 episodes that the NIH study called WHI, the Women's Health Initiative study, had 3 major weaknesses, huge weaknesses. And I'd like to summarize them here again, because you can't hear those enough, really. Number 1, this study chose a hormone therapy, which was mainstream at the time in 1990s, but is now used by less than 40% of women, likely 20% of women who are on hormone therapy today. And to keep it very brief, the study looked and used synthetic non-bioidentical estrogens. Again, they were mainly composed of estrone, about 60% of it, as well as Equilit, which was a combination of equine horse estrogens, there are nothing like human estrogens, and that was a proportion of about 30%. Literally less than 5% was pure estradiol. Now, obviously, in today's day and age, we have pure bioidentical estradiol in many forms. Patches, rings, gels, pellets, including oral pills, which obviously are not preferred. By that time, in 1991, when the study was started, oral synthetic estrogen, as Premarin or Prempro, was the mainstream type of hormone therapy available in the 1990s, and it had a rather good record of safety. So people do like to point the finger. Hey, this was a major weakness. The wrong hormone was chosen. But this hormone had been used for 50 years, from 1942, when it was FDA approved, until the time of the study, actually until the time of the study was released, which was 2002. So we're looking at about 60 years, 6 decades. It was used successfully to improve women's life after menopause. Now, as soon as transdermal estrogen became available in 1980, it was very clear that the bioavailability as well as the adverse consequences and side effects of transdermal estrogen were very different than oral estrogen. It had a better safety profile. It is well known today, as it was in 1990, that oral estrogen increases risk of clotting. Increased clotting is associated with an increased risk of negative consequences for a woman's cardiovascular system. This was the second huge weakness of the NIH Women's Health Initiative study, choosing oral estrogen. The WHI study was focused on proving or disproving that estrogen, either alone or in combination with a progestin, has a favorable effect on the cardiovascular health of women after menopause. Remember, this was a study ran by the National Heart, Lung, and Blood Institute, designed and ran by cardiologists. They used what was available, what was cheap and donated to them, and what also had a very good safety record. It had been used to help women for 60 years prior to this and was FDA approved. But wait a minute. We already knew at that time that oral hormones increase risk of clotting, which was bad for the heart and the cardiovascular health. But we're going to study it anyway, which was probably a good idea because people were making all kinds of claims and telling the doctors and the women, and the doctors were telling their patients that this will protect their heart. And a lot of this was going on, and we wanted to know if it was true. So the reason for the study was very, very good. There were other reasons for the study. It was also meant to confirm that heart disease, but also breast and colon cancer and bone fractures from osteoporosis in postmenopausal women could be helped and alleviated by estrogen in menopausal women. Now, in case you wonder why I keep coming back to this study, why I keep discussing it, is because this study's findings are the main argument doctors and public opinion use as a weapon, or let's call it a shield, against estrogen for menopausal and postmenopausal women. Yes, it's true, this study was seriously flawed, but it was the best of what was available at that time. It was conceived and designed mainly because very large observational studies had indicated that there was a significant benefit from using either Premarin, which was estrogen alone, or Prempro, estrogen with progestin. The makers of this medication, the company that made it, believed in its outstanding benefits for aging women. The doctors were told to believe in it, and they did. I was around. In 1997, I started my residency program in LSU, New Orleans, and I graduated in 2001. So I was around when all of this happened. I was a practicing physician. I've seen it. I witnessed it. The patients were told to believe in it, and they did, because they felt so much better when they used it. There was significant observational data that both Premarin and Prempro could decrease the risk of cardiovascular events, which would have been a huge thing. The top cause of death for a woman after 50 is heart disease, not breast cancer. So the one and only purpose of this study, the main purpose, was to show whether the estrogen protection for heart disease was true or false for postmenopausal women. So you might say, wait a minute, we're talking about timing of estrogen. How are we talking about the cardiovascular negative or positive consequences of using estrogen, I am rounding it up and I'm coming right there. So hang on there for a minute. What was interesting about this study, it was also set to analyze not just the health of the heart and the cardiovascular system, but it also looked at other measures of health. Breast cancer, lung cancer, colon cancer, and osteoporosis. Those were the top causes for morbidity and mortality, and they still are for women as they age. Now, here it is. The truth was very evident and indisputable, and it was released in 2002. Oral synthetic horse estrogen in the form of a pill, either alone or combined with the synthetic progestin, will increase the risk of stroke and heart attack. So it should not be used for this purpose. Now, there were many other findings that pointed very clearly to the fact that estrogen alone might actually have a benefit and decreased risk of breast cancer. That was released in 2004. It was lost in all the noise created by the previous findings. It was also very clear that estrogen, either alone or in combination with the progestin, could decrease the risk of colorectal cancer, and that estrogen, either alone or in combination with the progestin, would definitely improve osteoporosis. None of these findings mattered because what was shouted from the rooftops and what made headline news for all the world, including the medical community, was the fact that estrogen increased risk of breast cancer by 26%, as well as increased the risk of heart attack, stroke, and clotting after menopause, so it should not be used for this purpose. Now, the truth, as I laid it out for you in the previous episode, was that synthetic horse hormone combined with progestin will increase the risk of breast cancer by 26%, relative risk increase, which in terms of absolute risk increase, which is really what matters, it literally took the risk from 0.3% to 0.38%. Small and insignificant increase. However, it shaped the next few decades following the release of the findings of the study because it altered the medical community perception of estrogen risk, as well as the public opinion of perceived estrogen danger. And it is still impacting women today. As it turns out, women did not care much about the heart risk. They all care about the breast cancer risk. And I'm coming to the timing of the hormone therapy, believe me. In order to point out why the timing matters, let's point out the number 3 major weakness of this study, which was the fact that the population chosen to enroll in the study were women who had never received hormone therapy between the ages of 50 to 79. So they picked whoever was alive after menopause, right? Whoever was alive past 50 was a candidate. However, the median average age for all the women in the study was 63 years old. So basically, the study enrolled the great majority of women who had already spent a decade in menopause, post-menopausal, a decade of estrogen loss. Even though the cardiovascular risk of heart attack and stroke were increased in the treatment group compared to the control group, what was very interesting, and again completely lost in the noise, it was that it was universally clear that using estrogen, even orally and even with the oral progestin, even estrogen from a pregnant horse's urine, can actually improve the cholesterol numbers and the lipid profile for the treated women versus the placebo control group. You can just stop me here and rewind me. This is very important. Now, in my mind, as well as other people's minds who are using common sense and logic, especially logical reasoning, it should be clear that even though estrogen therapy improved the lipid panel profile, probably better than a statin, allowing more than a decade of no estrogen to pass in a woman's body will have undeniable, irreversible consequences for their cardiovascular health, which cannot be reversed by simply using estrogen. Probably not reversed at all. Now, this is a microphone drop moment. Feel free to rewind and replay me because this was the truth. This was the revelation that anyone should have focused on when the study was released. allowing too much time to pass between menopause and treatment with estrogen will allow aging changes of the blood vessels and likely the heart to the point where using oral estrogen could be detrimental and increase risk of heart disease. This is fact. This is the truth. This is what the study revealed. Now, this study had many weaknesses, and the data was presented in such a manner and sensationalized to the point where, perhaps intentionally or unintentionally, the purpose of scaring women off estrogen therapy after menopause was achieved quickly and effectively. Within 2 years or less from the release of the WHI study findings, so basically by 2004, estrogen's reputation was damaged, and it has taken a lot of effort to reverse that damage. It took one study, large study, sensationalized in its findings, poorly designed, and with facts that were reported in an exaggerated negative manner to destroy the good name and the good reputation that estrogen had been building for the past 6 decades. What was not obvious to the analysts of the study was the reality as far as the cardiovascular health. That's what I'm focusing on right now. The reality that the timing of estrogen therapy for menopause, and especially when it comes to the heart, could mean everything. Starting too late will have consequences. Starting estrogen after irreversible changes will have already occurred in a woman's endothelium, which is the blood vessel lining. Starting estrogen too late after the hardening of the blood vessels in the body has already happened. Starting estrogen after 10 years or more of exposure to the loss of the anti-inflammatory benefits of estrogen. Likely all of these factors together, everything I just said, is going to contribute to more and more and more advanced plaque formation in the time that passes from menopause until estrogen therapy treatment. And this was what was cleared from the study, that estrogen therapy started late post-menopause will not be able to reverse any of the cardiovascular changes, even though it improves the lipid profile in women. This is really what the study truly showed. It did not show that taking estrogen after menopause or during menopause is not going to protect the woman's heart and cardiovascular system. It did not show that it won't be protective. It simply showed that should you wait a decade or more, estrogen therapy will not be beneficial, will not be able to reverse any of the changes that have already happened to your cardiovascular system due to the loss of estrogen and aging. Now, interestingly enough, even though the women enrolled in the study didn't receive any estrogen for more than a decade, once they received estrogen for 5 years or more, their bones got better. Osteoporosis was improved, the risk of fracture was significantly decreased. Even though osteoporosis improvement was one of the fundamental health parameters analyzed in this study because it's a major source of morbidity and mortality for women, no one shouted it from the rooftops, not like they did regarding the breast cancer risk increase. Now, here's the thing you might not know, and I keep promising I will do a podcast on menopause and osteoporosis. I will. But just as a FYI here about what we're talking about, the standard of care for osteoporosis in 1990 used to be estrogen therapy. Now, fast forward to 2025, the standard of care for osteoporosis treatment is anything other than estrogen, is whatever big pharma tells you is the newest drug for osteoporosis. The benefit of hormone therapy for osteoporosis improvement, which was clearly highlighted in the findings of the WHI study, was literally lost in the hullabaloo sensationalism of reporting all the bad outcomes and painting estrogen all over the world as a very dangerous hormone. However, the truth always surfaces, and people take stuff that has been there for 20 years, and now they have a megaphone. Now they're shouting it from the rooftops. the truth surfaces, and it did. Many people, researchers, analysts, reporters, writers, doctors, pointed out its weaknesses over and over again. I am doing the same here with this podcast as well. However, all these voices were not strong enough because facts started to resurface immediately after the findings were released. However, the voices were not strong enough or loud enough to undo the damage that happened in 2001. There's still a lot of noise, and we really have to shout over this noise to make ourselves heard when we speak the truth. All you have to do, and what I recommend that you do, is search on Google for weaknesses of the WHI study, or search for flaws of WHI study. And a ton of very valuable opinions and information will pop up if my podcast episodes about this have not been enough. There is abundant proof that what you were told about the dangers of estrogen is simply not true. It is obvious and clear to many that mass media focused on the wrong information, as well as the fact that researchers and scientists did not put together what was very obvious and very clear. And I'm going to summarize it here for you. Using a synthetic progestin is to be avoided, as it will increase risk of cardiovascular events, dementia, and breast cancer. What should we do instead? Use bioidentical progesterone. The researchers that dedicated a decade to the study that rocked the world, unfortunately, did not have the option of micronized oral progesterone when they selected the hormones they should use. Micronized oral progesterone was introduced and approved by the FDA in 1998. The study was already 7 years into the making. Also, it was pretty expensive to procure. When you do a study for tens of thousands of women, you need something cheap or something that will be offered to you for free. Otherwise, it will cost an arm and a leg. And we already know women's health research initiatives are just not really happening. The company which produced Premarin and Primpro offered their product for free. The sales of their product were worth over $1 billion annually in the late 1990s. Fast forward to what $1 billion would look like today, it's a lot more than 1990. Imagine how much richer that company would have been if the observational studies that estrogen benefited and prevented heart disease in women as they age would have been confirmed by the WHI study. They were already capturing the market of the aging female population, which was and still is an outstandingly large and growing population. That company would have been one of the richest, if not the richest company in the world. Now, why was there such a discrepancy between the observational earlier studies that said, hey, estrogen might help heart health in women, and the actual WHI study as far as the heart health benefits? I will come back to this question, but let me continue summarizing what we really learned from the fallacies and weaknesses and flaws of the WHI study. No progestin is bad for you. Using oral estrogen for hormone therapy during and after menopause in a time period when we have so many safer alternatives like transdermal estrogen or vaginal estrogen should be avoided. Oral estrogen increases risk of clotting and has inflammatory consequences for a woman's cardiovascular system, increasing risk of stroke and heart attack. There is also no mention of what this oral hormone therapy could have possibly done to the livers of the women that took it. Tens of thousands of women enrolled in the study over a decade took this oral hormone that went through their livers. The first pass liver metabolic effect for steroid hormones, that's what the sex hormones are, by the way, steroid hormones, was and has been well known since 1960s when it was discovered. And why look at the study without analyzing the consequences of the liver health as a marker to also monitor? Again, it seems to me that some hormone experts should have been consulted when the study was designed, but that just wasn't what happened. So We also learned from the flaws of the study that the timing of hormone replacement therapy plays a very important role in the consequences of such hormone therapy. We learned, and this was the truth that should have been made available to everyone, that waiting too long will clearly have consequences for a woman's cardiovascular system that are likely irreversible. The formation of plaque and the stiffening of the blood vessels, including the arteries of the heart, due to aging and likely due to the loss of estrogen, is not going to be reversed by initiating hormone therapy after 10 years. So we learned that timing matters. And scientists, hormone experts, different doctors, researchers are still trying to figure out what is the optimal time to start hormone therapy for a menopausal patient. What is the best time to start before it's too late? They're also trying to understand what is too late. Is it a year without hormones? Maybe 2? Is it 5 years without hormones? Well, we certainly know that 10 years is too late. And here's my question to you. Why are we spending time and energy and money studying what we know is obvious? Estrogen is vital for a woman's body. Not because I'm telling you it's vital with this podcast, but because science and research have demonstrated and provide abundant proof of how vital estrogen is. If you don't believe me, or you have any shred of doubt in your mind about how vital estrogen is for a woman, please ask Dr. Google. There's plenty of information in there for you to make up your mind that you would have never become the woman you are today without estrogen. That your spouse, your mother, your daughter, your grandmother, your friend, your colleagues would have never been who you know them to be today if it hadn't been for their estrogen. So why wait for a certain amount of time after we lose this vital hormone? Why wait 6 months? Maybe because we want to make sure that we lost it completely. But when you don't have periods anymore, it's clear you don't have it anymore. But why wait a year? Why wait 2 or 5 or 10 years? It makes no sense. I understand your doubt. Let me tell you a little bit about my own hesitations. In 2016, about 10 years ago, I stopped getting periods. I wanted to allow my body 8 months of, let's call it menopause suffering, because I personally wanted to feel menopause in my body. I wanted to understand what it is physically, mentally, emotionally, and I wanted to see if hormone therapy was necessary for me. I had just started my private practice 2 years previously to entering menopause. I had stopped working for the community health center totally and completely. And in 2016, my practice was still growing. I was only 3 years into its journey, so I was not very busy. I had a very nice balance of work and relaxation time. My Thursdays were my me days. I would spend my me day learning how to horseback ride, going to yoga, getting acupuncture, getting massages. I would do some admin work and catch up with the previous 3 days and then prep for Friday and early next week. I loved my life. As my practice continued to grow and demand for my services increased, I lost my personal me day. That year in 2016, I believe, was my last year of using and having a me day available to me. I remember that time very fondly. I had time to relax, to read, to enjoy life, to do things that brought me pleasure and were fun. I had time to cook healthy meals. I had time to exercise. I had a great balance between work and play. But in spite of that, I gained 10 pounds. My sleep was horrible. I was moody and irritable. I was cranky at work, which cost me a few very good employees who could not or would not put up with my mood swings, and I don't blame them. My stress tolerance was significantly lower than it used to be, and anything small, any challenge, any hurdle would trigger me. I was constantly tired. I did not feel good. I felt achy and stiff and had significant discomfort in my chest area over my costochondral joints. I did not have hot flashes and night sweats to the extent that they bothered me. They didn't really wake me up at night. What bothered me is needing to wake up to go to the bathroom at least 2, sometimes 5 times a night. My bladder was waking me up, and then I just couldn't fall asleep anymore. I asked for it. I personally wanted to experience what menopause felt like in my body. I had doubts about whether or not I needed hormones. I was a trained OBGYN. I was a board-certified anti-aging doctor practicing hormones for many years. In 2016, I had been practicing bioidentical hormone therapy for at least 6 years, and I was also practicing hormone pellet therapy for at least 2 years. I could literally see firsthand the extraordinary improvements women were able to achieve in a matter of weeks or months, and I still doubted, and I did not want to confront the reality that hormones might be good for me. I was aware of the fact that hormone therapy is a replacement for something a woman has lost forever. So hormone therapy looked to me like a big commitment, maybe a forever commitment. Well, I did not get married until I was 40, and I've always had some long-term commitment issues. This personality trait also applied to my decision to start hormone therapy, something that I was aware I could stop at any point in time, at any given minute. It is normal to feel hesitation. I hesitated. Most women who are on the fence or hesitate about whether or not to try hormone therapy after menopause do so for a very clear amount of reasons. Number 1, they're concerned over risk of cancer. Number 2, they're worried about possible side effects. Number 3, they're worried and afraid over the possible reality of needing hormone therapy for a long time, maybe all the way into the 80s and beyond. They worry about cost. And number 4, they procrastinate and worry about which hormone therapy is best for them. Now, the one and only reason why women are really held back from a decision which would extremely likely improve their health and the quality of their life is fear. Fear of what they might experience, fear of side effects, fear of cancer, fear of cost, fear that it might not work for them, fear that they would have to use it for too long. Women are brave warriors. Do not be afraid. If I were to give you any advice, is to stop being afraid. After 8 months of experimenting, I decided to use hormone replacement therapy, and I never looked back. I will end this episode urging you to be courageous. You do not have to continue a therapy that does not agree with you. There are many options and there are so many solutions. There are many doctors that can help you. All you have to do is decide to take the first step. Do not hesitate too long. Do not procrastinate for too long. Your indecision and your delay of treatment will impact you. And timing of hormone replacement therapy is crucial to be ideally with as little lapse in loss of estrogen as possible. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas, so please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.